Thank you so much for the opportunity to present today. I'll be talking about laparoscopic liver resection as a tool to improve outcomes in obese patients undergoing liver resection. We have no conflicts of interest to disclose. Obesity has been termed as a pandemic involving the developed countries. The prevalence has steeply increased to involve 42% of the American population. With this increase, there's been an increased rate of NAFLD with increased rates of steatohepatitis, cirrhosis, and hepatocellular carcinoma. It used to be considered as an independent risk factor for post-hepatectomy morbidity and mortality, but most of these studies were done on patients undergoing open hepatectomies. Recent studies done on patients undergoing minimally invasive hepatectomies have shown that they have shorter length of stay, reduced blood loss, as well as reduced postoperative pain with similar oncological outcomes. Additionally, there's now a concept of obesity paradox that states that there's poorer surgical outcomes in patients on either extreme of the curve, that is the severely malnourished and the morbidly obese as compared to the moderately obese patients. Our aim was primarily to determine an association between obesity and postoperative morbidity after laparoscopic liver resection, and secondarily to determine an association between obesity with individual surgical outcomes after laparoscopic liver resection. This was a retrospective analysis of all adult patients who underwent laparoscopic liver resection by a single HPB-trained surgeon in a community health setup between 2013 and 2020. The patients were classified into obese and non-obese groups with a BMI cutoff of 30 kg per meter square. We did the statistical analysis using Fisher exact test for categorical variables, student t-test, and Mann-Whitney U-test for the continuous variables. We then did logistic regression analysis to establish an association between obesity and composite complication rate. On looking at the demographic variables, the patients in the obese group had significantly lower rates of previous abdominal surgery and malignant diagnosis at the time of presentation. On looking at the operative outcomes, comparing the two groups, there were no differences noted in the intraoperative outcomes, including the estimated blood loss, operative time, and conversion to open surgery, as well as the postoperative outcomes of bleeding, bile leak, infection, cardiorespiratory complication, rates of serious complication, length of stay, reoperation, and readmission within 90 days were all similar between the two groups. We then created a composite complication rate, combining the total rate of bleeding, infection, bile leak, as well as cardiorespiratory complications, and compared it between the two groups. On univariate analysis, there was no difference between the two groups. We then did a logistic regression analysis showing that there was no association between obesity and the composite complication rate after adjusting for past liver surgery, alcohol use, and neoadjuvant therapy use. In conclusion, obesity is not associated with short-term morbidity and mortality after laparoscopic liver resection. It is a safe and feasible procedure in obese patients, even in the community setting. We do want to acknowledge limitations of a retrospective analysis leading to selection bias, no comparison with an open cohort, as well as a limited sample size. We recommend future large multicentric randomized studies to analyze the impact of obesity on surgical outcomes after minimally invasive hepatectomy. Thank you. I can take questions.